congratulations on making it to the last talk of the last session of the last day. One disclosure from Dr. Dimmick, as noted there. The American College of Surgeons estimates that there are 93 million obese Americans in the United States. 11 million of them are severely obese. As bariatric surgery is one of the most effective treatments for morbid obesity, we now perform more than 179,000 procedures annually. However, despite the effectiveness of this treatment, there's also been significant perioperative concerns related to it. This report in 2005 by Dame Flum demonstrated that 30-day mortality rates were as high as 9% in low-volume centers. This news was quickly taken up by mainstream media, including the New York Times, that quickly put a lot of pressure on surgeons and surgical societies to try to address safety for this procedure. In response, leading surgical societies, including the American College of Surgeons and the American Society of Metabolic Surgery, created centers of excellence. Center of excellence criteria included facility requirements, such as having obesity-appropriate operating rooms, staff requirements, such as having board-certified surgeons and appropriate consultants to handle complications associated with this procedure, and a volume requirement that each of these centers perform more than 125 procedures annually. Over time, initially, the complication rates after initiation of centers of excellence did decrease, but it seems to have leveled off. Importantly, during that time, many centers underwent changes to obtain accreditation as a center of excellence, and currently we now perform nearly 90% of our procedures in center of excellence. With that in mind, we thought, so what can we do next to improve quality for this operation? And so we wanted to explore, to what extent do centers of excellence uniformly provide high quality care? We use data from the Healthcare Cost Utilization Product State Inpatient Database. This is a collaboration between individual states and the Agency for Healthcare Quality and Research to review patients between 2009 and 2011 who underwent one of three procedures, a lap Roux-en-Y, a lap band, or a lap sleeve. In total, we had 137,000 patients who underwent surgery at 188 centers of excellence. We define quality as rates of serious complications. We use standardized definitions previously described in bariatric cohorts. These included medical complications such as cardiac arrest, pulmonary embolism or stroke, surgical complications including reoperation, bleeding, or dehiscence, or mortality, which we defined as a death within 30 days of the index operation for any reason. In order to make these comparisons fair across different centers of excellence, we had to account for different case mix. To do this, we used a multivariable logistic regression model to risk adjust our outcomes. That included patient factors, the comorbid disease, and the type of operation that was performed. Additionally, even after risk adjustment, there is some variation that's observed that may be due to the quality of the signal from each individual center. So additionally, we performed a reliability adjustment. What this effectively ends up doing is shrinking the variation that we see across the centers. And a primary advantage of doing that is it avoids the risk of misclassifying lower volume centers as either high or low performers. That said, so we had a total of 137,000 patients. On average, their age was about 44 years old. The majority were women. In addition to morbid obesity, the most common comorbidities were hypertension and diabetes. Of these centers of excellence that we studied, nearly all of them were in urban settings. The majority were in teaching hospitals, and they were overall pretty large settings. The average hospital here had 22 operating rooms. I'll take a minute just to orient you to this graph. This is rates of complications along the y-axis, and each individual bar on the x-axis is an individual center of excellence, and their risk and reliability adjusted complication rate, and they are in rank order from highest to lowest rates of complications. When we look at all centers, we found 42-fold variation from the top and bottom performing centers, ranging from 0.3% complication rate within 30 days to 14%. When we broke this down by decile, the variation was about 12-fold from 0.5% to 6.1%. We wanted to look closer because a lot of these databases are organized by states to see if this variation also held up at the state level. So I'll just give you a couple examples. This is California, that has 46 centers of excellence, and they had 18-fold variation across their centers. New York, similarly, another place that with a large number of centers of excellence, that had 17-fold variation. And just continuing through, multiple states that we looked at had significant variation. So in conclusion, we found that wide variation exists in quality provided at bariatric centers of excellence. This variation is present both across the country and within states individually. This study should be interpreted in the context of many limitations. Owing to state privacy laws and the way each of these states have decided to set up their registries, we are only able to identify about 188 centers of excellence, which is roughly a third to a quarter of the current centers of excellence now. However, they were geographically diverse and represent different size states, so we feel it gives a fairly representative sample of what's happening in the country. Second, we relied on different diagnosis codes to identify complications, and there may be some variation in how surgeons code their complications for billing and other reasons. We use different coding algorithms to make it more sensitive and specific, and if anything, we're probably a little bit conservative in identifying complications. And then finally, due to the nature of this database, there are many important outcomes that weren't measured, particularly in bariatrics, effective weight loss. That was not measured in this study due to what was available in the database. However, that information is important in addition to the rates of complications and not instead of. So moving forward, referring patients to centers of excellence may not always have the achieved expected outcomes that we always hoped, and that because the majority of these procedures are now performed at centers of excellence, it provides a great opportunity for us to focus on reducing variation within these centers. I'd like to thank the Robert Wood Johnson Foundation and the Department of Veteran Affairs for funding my research time as a clinical scholar, and my co-authors is listed there, and I'll be happy to take your questions.